Hi, good afternoon, everybody. My name is Kudrna, and I'm from ARC West Midlands. I'm joined by Mackenzie Fong from ARC Northeast and North Cumbria, and also Austen El-Osta from ARC Northwest London. And today we're going to be talking about our study on workplaces, which is a mixed methods evaluation of cross-regional workplace health and well-being initiatives. Oh, can you not hear me, or? They seem to be able to hear me. Yeah. Okay. Right. So why are we conducting research? First I'll say we are joined by a very large team of researchers, practice partners, and patient and public involvement advisors across ARC NENC, Northwest London, and West Midlands. I wish I had the time to read out everybody's name. Just to say we're supported by a very strong and diverse team. So why study workplace health and well-being in a prevention program? Well, organizations worldwide, such as the World Health Organization and also nationally here in the UK, promote workplaces as an important setting for health promotion. Decent work is good for mental health, here from the World Health Organization. However, the evidence about the effectiveness of workplace health and well-being programs is quite poor. Here's an article from the New York Times a few years back talking about how workplace wellness programs don't work very well, despite the fact that some studies show otherwise. And there's quite a bit of debate in the literature about if we should be intervening in workplaces at all because of the lack of evidence about effectiveness. Here's a quote from one of the studies that came out in the last couple of years that's been quite criticized. "What do workplace wellness programs do?" Was the title of one piece of research, and this author has said a more appropriate title might have been, "What did the University of Illinois Workplace Wellness Program do in a very short amount of time?" So the academic debate is quite vigorous. So what are we doing? We are conducting 3 linked research projects across our 3 different regions. This is a way of conceptualizing the work that we do. It's similar to the Dahlgren-Whitehead rainbow model of the determinants of health that you might have seen before. We're conducting research at the employee level, the employer level, and then also at the level of the wider context and mechanisms. At the employee level is what we're doing in ARC West Midlands with a local government health and well-being program called Thrive at Work. In ARC Northwest London, the Self-Care Academic Research Unit is focusing on the employer level. And in ARC Northeast and North Cumbria, they're focusing on wider contexts and mechanisms, looking at the local government health and well-being program called the Better Health at Work Award. We have 3 research questions associated with each of these 3 work packages. Number 1, what are the mechanisms through which workplace health initiatives prevent context-relevant ill health and well-being outcomes with ARC NENC? How do workplace health initiatives help employers support their staff in identifying and addressing barriers and facilitators to adopting healthier behaviors, such as individual competencies and self-care behaviors? And finally, what is the effectiveness of a mental contrasting intervention delivered through workplaces in motivating staff to change their health behavior and well-being? We have 2 cross-cutting themes that are similar across the ARCs and work packages. One is on inequalities. We're looking at any differences according to subgroups such as age, ethnicity, and gender. And we're also using normalization process theory as our implementation science framework in order to understand the ways in which interventions and initiatives become adopted as part of normal practice. I'll hand over to Mackenzie to discuss what's happening at NENC.
Thanks, Laura. So as Laura mentioned, our work package focuses on an evaluation of the Better Health at Work Award. So over 400 employers are currently enrolled in the program, so it has a reach of about 250,000 individual workers. Enrolled organisations are essentially supported to implement health-related policies, so they might target individuals, it might be provision of a counselling session, they can work at organisational level, so it might be the implementation of a flexible working hours policy, but it might also tackle the workplace environment, so it might be the installation of a healthy food vending machine, for example. So the organisations kind of evidence all these interventions that they've rolled out in their workplace. That portfolio then goes to an external assessor. They assess the evidence against the award criteria, and all going well, that organisation will receive an award. So they'll start at bronze, work their way up to silver, gold, etc. Oh no, you haven't seen the beautiful diagram you were meant to be seeing as I was saying all that. So as the initiatives are bespoke to each individual organisation and the participating organisations vary by size and sector, we thought that rather than an effectiveness evaluation, that a realist approach would be more appropriate. So realist-informed evaluations are more concerned with understanding and explaining causation. So instead of asking, does Better Health at Work award work, we're asking for whom does the award work and in what context. So basically the way, I don't know if anyone's was in the talk in this room earlier, but it was explained much more articulately than what I'm going to do. But basically critical realism sets out a particular worldview that an intervention outcome, so the O, is driven by a mechanism, M, that may function differently according to a context, C. So you have these CMO configurations. So for example, you might have a workplace where the culture is really positive, that's the C. Because employees are happy in their workplace, they might perceive the award to be more effective, that would be the M, and the outcome would be that the uptake of the intervention is higher, that would be the O. So in terms of where we're at, the realist-informed evaluation process is very iterative, but we start at the top and develop our middle range theory. So to do that, we've talked to a bunch of different stakeholders, including the program coordinator and public health stakeholders. We've consulted the literature, and we're also updating a realist synthesis. And then the next step, once we've got our initial program theory, is to go out into the real world and test this with our case study organisations. So we've identified and recruited 6 case study organisations, all at Gold Award, and they vary on industry, size, and a mixture of entry-level and professional roles. We're going to collect data. We've collected secondary data through their assessment portfolios, and we've started to draw out those CMOs from the portfolios, and we're also doing some primary data collection. So we're going to do interviews with different workers, senior middle management, occupational health. And so once we've once we've synthesized and analysed all that data, we then go back to our original theory and hopefully develop our final program theory. So Austen, I'll hand over to you.
Thank you, Mackenzie. Hi, so I'm based at Charing Cross at Imperial, so I'm happy to talk to you about work package 2 of the program. So what we're really trying to do is to characterize the barriers and drivers for the adoption of health-seeking behaviors in the workplace. So what is it that employers could do to help staff be healthier in the workplace? We dwell a lot at work, or some of us do anyway. And this really fragments into 2 things. There's a study we're calling the competence study. It's an e-survey interview-based study that we're doing. And also some work on characterizing the best buy interventions. So the WHO published the best buys for NCDs some years ago. We know, for example, tobacco control and otherwise. So the big question here is, what can employers do, cheaply probably, what are the best buy interventions for workplace health promotion? And our approach for this is a rapid review, which we've nearly completed, of existing workplace health promotion chartered initiatives in the UK. So there are many of them. We included 10 in our analysis. And the main study here then is to survey the attitudes, knowledge and experiences of staff and their employers using an e-survey interview-based study to identify, which bit of self-care are easy to work with, what's the difference between occupational health, MSK, and workplace health. Do people know there's a difference, and so on? So that's what we're doing. And our interim findings, starting with the best buys on the left. So we identified 25 initiatives in the UK, and we included 10 in England in the final analysis. And we clarified 54 unique recommendations that we felt were cross-cutting in these documents that we analyzed across 5 categories. And here they are. There's mental health, there's MSK and physical activity, 13 recommendations for that. Lifestyle and healthy eating, of course, really important. Health screening, it came up a lot. Whose responsibility is it to do that, and so on. And risk mitigation. There's another category which we haven't included, disabilities, inequalities, but that's also cross-cutting. And for the and that's I think we're done. And the surveys, we have ethics for that. And finally, we want to triangulate with the WHO best buys and the 7 pillars of self-care framework and the self-care matrix to see what is it that employers can do to improve the health and well-being of their staff. Thank you.
Thanks, Austen. It's So really briefly, what are we doing here in the ARC West Midlands? We're evaluating an intervention called WHOOP, which is a goal-setting intervention that's been effective in systematic reviews going back about 10, 20 years. We've registered our protocol for the evaluation of this in workplaces on the Open Science Foundation, and it's under review at +1. We co-created the mode of delivery for the WHOOP sessions. They're group sessions in a digital and in-person format, which we adapted for the UK context and the local government health and wellbeing program. We are currently in the process of enrolling organizations and running the WHOOP intervention and data collection and intervention sessions. We've completed 4 thus far. We have 8 booked, and 20 further are interested and about to be booked. In terms of fieldwork observations, we find that it's really difficult for employees to participate in the sessions because employees are quite tired. The initiative involves going slow, which is really difficult for them to do, and many find that setting a health or well-being goal is not familiar to them. We find participants saying that they've never set a health and well-being goal before, and that's not something that they've thought about. So in terms of kind of next steps, we're all in our data collection phase, and we will be finishing that over the next couple of months and summarizing and synthesizing our findings across work packages. That's it from us for now. Thank you.
That's great. Thank you very much.